Okay, Sarah, sorry, I've been having technical difficulties this morning. Are we ready to go?
I think so, yeah, and no problem.
Great. Welcome everyone. I feel like the latecomer. I walked in late. Okay. Awesome. Here we are, January. So welcome to our January meeting. And let's see, do we read? Let me see, we read the opening. Okay if I do that? This meeting is being held virtually and is hosted by the Utah Department of Health and Human Services, Center for Medical Cannabis, based in Salt Lake City, Utah. Public notice of this meeting was provided as required under the Utah Meeting Code. Let me move this over here. And posted on the Utah Public Notice website. The purpose of this board is to review the available research literature and assist the Utah Department of Health and Human Services and Center for Medical Cannabis in their efforts to provide useful treatment recommendations to qualified medical providers regarding the use of cannabis and cannabinoid products for the treatment of certain medical conditions identified as qualifying medical conditions. This meeting is being recorded in compliance with Utah's open meetings law. A recording of this meeting will be posted to the Utah Public Notice website within 3 business days following the date of this meeting. Written minutes will also be prepared for this meeting. Approved minutes will be posted to the Utah Public Notice website within 3 business days after board approval. Let's see, are you sharing your screen?
I think so. Can you guys see it?
Yes.
I just see you, Sarah.
Oh. Can other people see my screen? I'm trying to share the copy of the slides.
Yes. We can
Yes.
see it.
No.
I can see the board members list right now.
Good. I don't know why I'm going to exit the full. I don't know why I'm just seeing everyone who's speaking. Okay, there we go. That's better. Okay, so they're the board members and the Department of Health staff. I won't list everyone's name. It's written there. Finally, you have 2 minutes. There at the end of the meeting, there will be a public comment period. You have 2 minutes to make a comment. Select raise your hand function on the bottom of the right-hand screen, and don't forget to deselect it when you're done. State the following: your name, and if you have any formal affiliation, or conflict of interest, and then what your comment or question is. As a courtesy to everyone participating, please put yourself on mute unless you're speaking, and then board motions and votes will be recorded in the minutes. We will now turn our attention to the agenda. So first of all, we have some business items to take care of. We have our October minutes to review and approve. I hope everyone was able to review the minutes beforehand. So if you have, Sarah will put them up. These are the minutes of the meeting last October. Does anyone have any corrections or additions to the minutes? As a review, we talked about the multiple sclerosis update that we provided and approved that. And then we talked about Crohn's disease and ulcerative colitis. It was a really great discussion reviewing the research. And I think, well, we're going to approve that next. But any call for any discussion on the minutes?
Matt, I would move to accept the minutes.
All right, thank you, Misty. We have a motion to approve the minutes. Do we have a second?
I'll second. This is Russ.
Seconded by Russ. Thank you. Any discussion before we vote? Okay, well then let's vote on the minutes. All in favor of accepting the October minutes, please indicate by either saying aye or raising your hand. Great. Any opposed? Fantastic. Unanimous again. We have such a great track record. All right. So let's move to the next item, approval of the draft for ulcerative colitis and Crohn's document. If you put that up, Sarah. As you recall, we talked about the research with these conditions, which was scant, but we did make some additions to our previous document on these topics and adding evidence of improved quality of life. As you recall, it didn't show much evidence for disease modification or reducing inflammatory markers, but it did have limited evidence suggesting it improved quality of life, which for those people is a good thing. So Sarah, if you would put up just the additions.
Mhm. Can you guys see the document or?
No.
I see the
No, just,
agenda.
I see the agenda.
Okay, hold on 1 second. I just gotta switch my screens.
So thanks to all the Sarahs in the Office of Department of Health, which there are several. You can see this is the previous document, and then the additions were in red, I think, and then on the right side you can see sort of who put the additions in there and sort of the editing process.
Yeah, we incorporated what we discussed in the last meeting and also did some updates to the references that were listed in the document as well. So a lot of those edits are references.
Yep. So you'll see the stuff in red, the 3 trials measuring quality of life, all that was added in with the references. And hopefully you had a chance to review this before the meeting. I think it looks good. So
I agree. Looks good to me.
great, Russ. So was that a motion? Is that what you said?
Oh, you want me to make, I'll make a motion, sure. To approve the additions, yes.
Awesome. We have a motion to approve. Do we have a second?
I will second it. This is Misty.
Seconded by Misty. You're reversing roles again. You guys are awesome. Okay, so before a vote, now that we have a motion to approve and a second, this is last call for discussion of any edits or any changes. All right, hearing no call for discussion, then we move to the vote. All in favor of approving the updated recommendations on ulcerative colitis and Crohn's disease, please indicate, say aye or raise your hand. Fantastic. Any opposed? Excellent. The motion carries. So we will finalize this, Sarah. If you finalize it and post it on the website, that'll be updated recommendations. I hope to address this again someday, right? You know, we talked about that when we discussed it, that it'd be nice to have more evidence and research on those conditions in cannabis use, but at least we have recommendations on that it does, in fact, improve the quality of life in many patients with at least limited evidence. So the next step, I guess, is not part of our official protocol, but we want to work with the Department of Health is how do we now get this out there? Just like we did with MS, we now have an updated document. We'll post it on our website, but how do we notify qualified medical providers that this has been updated? Is there a routine email that goes out to that list of QMPs?
We could send one out to them, to the QMPs. I don't
I
know
think
if it's a routine one, but
I think that's a good idea. I don't know how the rest of the board feels, but we just did all this work on MS and Crohn's disease, and it's a minor addition, but it is an update, and QMPs ought to be notified that, hey, we have updated our guidelines. Because not only is it our job to review the research, but we need to notify relevant people that what we found. So
Matt, I think it
agree.
would be a great idea to not only send it to the QMPs, but also to notify other boards like the Medical Cannabis Policy Advisory Board, because it may inform decisions there. And even the Compassionate Use Board. I think it's important that we build bridges of communication.
yeah,
Good idea.
that's a great idea,
Agreed there.
Misty.
Yeah, this is Rich with the DHHS. One thing we can emphasize also is ensuring that those providers who are affiliated with those patients that have these conditions, that we emphasize that we would share with them for sure, because those would be those providers that are ongoing in their treatment of patients with these conditions. right? So, and I know we made sure that we sent invitations to join the previous Cannabis Research Review Board meeting to those specific providers that have those patients to the last meeting when this was reviewed. And we can just make sure that we also send them the audio of when it was discussed during the meeting so they can hear some of the back and forth between board members about the issue. So those are some thoughts.
That's also a good idea. So we could maybe craft sort of an executive summary in an email with the announcement of these changes, but then links to the video, links to the document. You know, I hope they read the document because it kind of shows the process that we went through. The recommendations might seem less than desired, but when they read the document, they realize, well, there's just not a lot out there, but there's a call for more. Everything that we review gives a suggestion about research that needs to be done. And so, okay.
Yeah, and just another thought on that, Dr. McKiff, is Sarah Ponce and I and Sarah Dash can talk about outreach to the pharmacies as well, to the pharmacists that work in those pharmacies about cases when we do make updates like this, right? And so they would be notified as well. And we will make sure it's added into the quarterly update that we do to stakeholders. Sarah Dash, I believe we've got a group of about 7,000 that we send that to, correct? And we can just make sure that it's mentioned in that as well.
You know, Rich, that's a great idea because, you know, the pharmacists, the way they're set up in Utah, have a huge impact on the treatment for patients. You know, they have the ability to, well, be almost a prescriber. The QMPs are in charge of approving the condition and making sure that the patient, that it's a useful treatment for them. It doesn't interact with their other medicines or other conditions. Those are their primary roles. Their tertiary role is to give advice on dosing and cannabis products if they feel comfortable. If they don't, then the pharmacist takes over. So the pharmacists actually have a huge part in clinical treatment of these patients. So yeah, I agree that they should totally be updated.
And also, we can talk about how to do outreach to the clinics as well, the actual clinics that employ a lot of the QMPs. A lot of them are signed up with our newsletter, with our update, but we can maybe brainstorm on how we could target them as well.
Would it be possible, Melissa Chan, talking, would it be possible to have like a embedded link that's in the EVS system that's always on the bottom right, or as you're logging in, that people can click on it when they're in there to go to the dashboard of where to find this instead of searching for a newsletter?
It's a great idea.
Let's chat with Amanda Hovermel, Sarah Dash, about how we can do that.
Yeah, I'm happy to look into that further.
Right. I mean, there'd be a question about how we can do it in our current EVS and then also long-term in the new EVS that's being designed and configured in preparation for launch later this year. We can make sure that we have a short-term plan and a long-term plan, because that's a good point, Dr. Chan, for sure.
Excellent. I love it. Okay. So next item on our agenda, we're going to have some public board training by Jeremiah Sniffen. Is that right?
Yep. Yeah. And Jeremiah, I can share my screen, or if you have it up, I'm happy to give you sharing access.
No, I think that works fine, Sarah, if you just want to advance it for me.
Awesome.
Hello, everyone. My name is Jeremiah Sniffen. I'm the policy coordinator for the Center for Medical Cannabis. I've also, I'm here today to do some public board training, just kind of some overview of how public boards are supposed to work. And so go ahead and hit next slide, Sarah. Okay, so part of this training is to ensure that public board meets the minimum 1 year training requirement. Also, the purpose of the presentation is to understand basics of how a public board is supposed to operate. Also, it gives an opportunity for well to learn about any new updated rules or statutes and how public boards are supposed to conduct themselves. And then also just a quick review of or provide some resources for the Robert's Rules of Order. Okay, so real quick, like what is a public board? Well, this is the Open and Public Meeting Act, OPMA. It basically stipulates that it's any administrative, advisory, executive, legislative body of the state or its public subdivision that is created with the Utah Constitution, statute, or rule. It consists of more than 2 people, expands, disperses, or supported in whole or part by tax revenue, and is vested with the authority to make decisions or recommendations regarding the public's business. Well, it's a meeting. OPMA defines a meeting as the convening of a public body or a specified body with a quorum present, including a workshop, executive session, whether it's in person or electronic communication. That really changed over the last 3-4 years with the COVID-19 pandemic as everything kind of moved to virtual. You know, it needed to be said that, well, we need to really allow for public boards to meet virtually as well. Anytime there's more than 2 people meeting for in a public board, it is considered a meeting. Okay, what's a quorum? A quorum means simply a majority of the membership of a public body, unless otherwise defined by applicable law. So that's a quorum. Okay, this is kind of tricky. What is a closed meeting? So a board may request to have a closed meeting, but it has to meet some stipulations. I'm not going to go over all of those, but if you're curious of what is a closed meeting, how can a public board move to a closed meeting, we'll share these slides or if they're already part of the agenda after this meeting. And you can click on the link there that says Title 52.4.205, and that will actually take you right to statute that explains these stipulations. Okay, public notice requirements. You guys have already done this, but I'll just go over it again. A public body that holds regular meetings that are scheduled in advance over the course of a year shall give public notice at least once a year of its annual meeting schedule. Okay, really quick, I'm not going to go over all this Robert's Rules of Order. There's a cheat sheet here that will kind of go over like how the ins and outs of how they're supposed to work. But essentially, why a public board uses Robert's Rules of Orders. This definition says it's really for keeping a standard of how nonprofit boards, committees, and other established groups such as yourselves are supposed to work. You know, how discussions are supposed to operate. How a board can maybe come to a consensus and really kind of discuss agenda items as they come up. Okay, I'm not going to go over all these, but here's some tips. At least 24-hour notice prior to public meeting. Be specific with agenda items. Roll call vote is required for all non-unanimous actions. This is kind of interesting. They recommend no old business, new business, meaning that, say in the last meeting, if the board has already discussed an item and it's already been voted on and it's kind of put to bed, really shouldn't bring it up, especially if it's not an agenda item in the next meeting. It really kind of needs to be considered old business and really for the boards to kind of move on and keep doing work. Not to kind of keep rehashing old things, especially if they've already been voted on. Or being tabled is a whole other situation where it's like, okay, let's discuss this further. But say if you already voted on something 3-4 months ago and it's already been discussed, already been voted on, and there's really no change in that, there's really no reason to kind of bring it up again. Provide minutes of timely matter. Don't text during meetings, you know, being professional. I think everyone here has no problem doing that. And then also, as stated, you're supposed to receive training at least once a year. And this presentation will check off that box of, okay, we received a public board training. Error inside transparency. And then when in doubt, consult your legal counsel if your board has one, or, you know, I would say in this case, you know, your DHHS provided consultants like Sarah Pond, Rich, those type of individuals. Okay, and I'm not going to go over all these, but here's some resources for you all. This presentation, the UPM presentation, this is one that our Assistant Attorney General Molly McDonald did for the Medical Cannabis Policy Advisory Board last year, which is also a good resource for this board if you want kind of a bit more specifics of OPMA. There's Robert's Rules of Order, and then also Robert's Rules of Order cheat sheet. And then I've also included Utah Code 52-4, which goes over everything regarding public boards. Lastly, is there any questions? I'm happy to answer any questions. And then also, if you kind of have any more questions later, you can definitely email me at jsniffen@utah.gov. Or talk. I would actually recommend talk to Sarah Ponce first, as kind of like your liaison from the CMC, and then her and I can work together if there's any other specific questions regarding anything that's discussed. Okay, well, thank you all for your time, and again, talk to Sarah Ponce if you have any other questions, and have a great rest of your day.
Thank you so much, Jeremiah. That was good. That was a good refresher. Yeah, any questions for Jeremiah? If he thinks of some later, Sarah will always be welcome to address them. Okay, moving right along, right? This is great. Item number 5. So the patient assessment screening tool. If you could pull that up, Sarah. This is an education piece. It was an attempt to try to describe the process that a QMP could go through in advising or selecting patients for cannabis therapy. Well, I wrote it last year at some point, trying to describe the process that go through, and it's presented here for review and edit if you feel like there's something to be added or subtracted from it. And it's really just trying to help QMPs or new providers sort of get a feel for what do you do when you consider cannabis therapy for a patient. You know, if they're new to that process, what's important to talk about. So it's kind of a brainstorm a little bit, but I tried to keep it to one page because it shouldn't be that complicated. But it's an attempt to really sort of outline what is important to talk about, what is important in patient selection, because I believe that's one of the most important parts of this you know, area is the right patients with the right medicine and for the right reason. So I'll just go through it really quick, and if you have any comments. So the first thing was a qualifying condition. We know that they need to have a condition that qualifies for medical cannabis. And then the absence of contraindications. Well, that's seems obvious, but this is kind of trying to be thorough. But I think it is important to list the contraindications, especially pregnancy, cardiac conditions, allergies, and then psychiatric diagnoses. I met with some other providers that really focus on psychosis and problems that patients can have using cannabis if they have active psychosis, or they might develop psychosis from cannabis use. And you know, we have a psychiatrist visiting with our board every month. You know, this is a huge topic. And then age and experience, cannabis therapy. We know that the younger the age, that's why we have a compassionate use board. The younger the age, the more side effects it can have. And with more age and experience, the experience with cannabis therapy can be more beneficial and safer. Experience with other controlled substances and treatments. Well, this is when you take a patient history. If they've used before or not, if they've used other medicines or controlled substances before or not, that can really tell you a lot about their responsible use, their tolerance, their dependence, their attitude toward use, a whole host of things, which leads into the next one, mindset about cannabis and willingness to be objective. Cannabis has a long, sordid history, and people have perceptions that might be unfair, inaccurate, extreme in one way or the other. And so as a clinician, I think it's important to assess that and see where they are and what their attitudes about it in order to promote appropriate and positive use. The ability to self-evaluate, calculate dose, and journal effects. I think this is really important. Cannabis therapy is not that simple. It's actually complicated. There's so many variations, and it's actually a complicated therapy. And is the patient able to understand how to self-evaluate and be objective about it? So I thought that deserved its own, address. Realistic expectations. This is also a big thing. It is a great medicine when used appropriately, but some people attribute more success to it than it really deserves, or have unreal expectations about their chronic, especially chronic pain. It's really helpful, but it's not going to make their pain go away necessarily, right? So expectations are really important. And this is standard for any therapy. This is what a clinician does. You have to set expectations about a surgery or anything. So it's no different here. And then that leads into goals of therapy. What is our goal? How do we know that when we've achieved success? If you've ever treated migraine sufferers, you know that this is really important. What is our goal? And then the last one is just simply having a good relationship with the patient. I think, especially as a primary care clinician, I think this is really important. You got to have trust, and you got to have communication if you're really going to have success. And so having a repeated and a good doctor-patient relationship is essential if you really want to have achieve those goals, understanding, and success in therapy. So that's kind of my list that I put together. I hope that it's helpful. I would invite any comments, critiques, or edits if you would like, if we feel like this can be useful as an education piece. So I'll open it up to the floor.
Matt, I was just going to say that here at University of Utah campus with the new Center for Medical Cannabis Research, one of the education things they're working on right now is for both QMPs and patients about how to talk to your doctor about medical cannabis and how to talk to a patient about it. And this would be like perfect for the scripting that they're working on. I don't know if you've heard about that or not, but we should probably get you connected with Valerie about some of this. I don't know what you think, Misty, or anyone else who's on that, to make sure that it sounds like you would be kind of the go-to person to make sure kind of the script, and they're very short videos that I think will be minutes. I think having your input with some of this into that educational material they're developing would be perfect.
Yeah, Matt, I would second everything Mike just said. This is actually something that is kind of an ongoing project with the center at the U, in addition to the videos that are being created, some being patient focused, some being provider focused, etc. So if you're willing to share that, I'd be happy to forward that to Valerie, whom I don't see yet. She was going to try and attend, but yeah, I think this would be a wonderful thing to add to the center as well.
Yeah, I just want to say, I think that's a great form. My name's April. I currently work with QMPs in the community, providing education and assisting them as they get into the program. And I've worked with some QMPs in the corporate settings who are in our bigger hospitals and really struggling with like that process. And I just want to say, I'm really glad to see this. We've had to create our own documents and forms at times to help doctors feel more comfortable, just because they are in that PCP realm. And while they're wanting to help, sometimes they're really uncomfortable because they have always been told something a little bit different. And I've met some really great QMPs who are excited to help, but it's just that little bit of, how do I talk to the patient versus do I just send them off to the dispensary? And some of them really want to own it and be accountable, but they were just confused on how to get started. So great job.
Awesome.
In the College of Pharmacy, this might be a great thing for us to provide to the students as well, as they're leaving our course.
Great
Because
idea.
in
Great
addition
idea.
to the QMPs, the pharmacists are really on the front line.
They are. So yeah, so let's edit this if needed, and then let's get it to Valerie and to whoever else can use. This is meant to be useful, right? We really want to not only do research, but it's meaningless if we don't teach. So and share. So let's share it. Absolutely.
Matt, this is Rich. Would it be helpful to set a date by which board members would want to share any modifications, suggested changes to this. And then if we set that deadline, then our team on our end can incorporate some of those thoughts that they share and then into the document. And then after that, the board would be welcome to request that it be shared with some stakeholders for their input to go beyond the board. And right now it's actually posted on our website, excuse me, not on our website, but on the public notice website as a handout. That's relative to this board meeting. And so the public is able to access it there. And so what are your thoughts about that, Matt?
Well, that sounds great. Deadlines, we all hate them, but they all make us move, right? So
Yeah.
deadlines are effective at getting people to get stuff done. So why don't we do it? And we can make it relatively quick because, strike while the iron's hot. If you have an edit or think about this within the next couple of weeks, let's at least do a couple of weeks, and then let's approve it and get it out there so that it can be used.
Yeah.
And I don't know if Valerie or what Mike and Misty suggest.
Hi, Matt.
A deadline.
I'm here.
Oh,
Hi,
okay.
Misty. Hi, Mike. Thank you. Yeah, we will make sure to definitely include this. And Matt, you have been on my list to reach out to. So I will make sure to connect with you on this. In addition, I was thinking we can always do some updates and include your guideline updates in our newsletters. To get it not just only out to researchers as they consider what projects they may want to expand on, since those were limited qualified quality of life updates. Maybe we can inspire people to do additional research on those areas, but also to share it not just with QMPs, but also with providers who may be working with those patients within the network there. So we will definitely support you guys as you guys update these things in disseminating information, but we'd love to include you in our videos. So that was on Jerry and my agenda to ensure that you were included in that.
Awesome. Thank you, Valerie.
Thank you,
Matt,
guys.
I apologize. This is the first time I'm really reading through it in detail, and I'd like time to look through it in more depth. But one thing I'd probably want to add is some comment. You kind of suggest interactions, but where you're talking about experience with other controlled substances, treatments, and medicine, I think we need to say something about potential interactions. Just outright say it instead of alluding to it.
Sounds great. Yeah, let's add that.
I can play with the wording there a little bit, but
please do. That would be great.
Because the safety really has to be focused.
Yeah, I agree. And I think I like the idea of keeping it to one page if possible, because my
Yes.
experience with QMPs is that you give them more than one page and they're like, it's too much.
Yep.
Yeah. Agreed.
Sarah Dash, would you create a Google Doc version of this
Yeah.
that you could share with board members, and so they can jump in and make a comment in preparation for a version that would be updated as we work through some of those suggestions? And I'm just thinking the deliverable that the board may want to work on in relation to this may be first is to share it with the University of Utah Center for Cannabis, Medical Cannabis Research, Valerie, of course, who has given her thoughts already. And I know Valerie and her team already plan on creating something similar to this. And so they can incorporate these principles and many of them into what they're moving on already. Right, Valerie? Does that sound right? You're with your team, I think
Yeah, that is part
right.
of what we've discussed with Sarah.
Great.
She's been an amazing help with that. So
Yeah.
part of our goals after establishing our video content is to move on to one-page summaries to make it easier and more digestible for QMPs. So
Yeah.
that is something that was part of the directives within the bill. So we'll
Great.
definitely be supporting you guys there.
Great. And one thing I can take a look at while we wait for that to be published in the future by the University of Utah Center for Medical Cannabis Research is maybe in the meantime, the board could make a recommendation to DHHS that we publish something similar that we feel okay with on our website. And then in the future, as we coordinate with the University of Utah, we would likely just want to refer to the same document that the University of Utah publishes. So that way we're consistent. So maybe the deliverable in the short term would be this, the board would be making suggestions for a cannabis therapy patient assessment tool that would be published on the DHHS website in the short term. And so when we share the Google Doc with you, when Sarah Dash sends that, you would be, sharing suggested changes and giving suggestions to the DHHS. And then we would use those as we consider what to publish on our website in the short term. And then long-term would be coordination with the University of Utah. Does that make sense? I think that's a very simple deliverable. And if we give the board a few weeks, let's say 3 weeks, does that work, Matt?
I think so.
Yeah. So if you have, if Sarah can get it out this week, Sarah Dash will send it out as a Google Doc, and then everybody can kind of share their thoughts. And then we'll then review that with Sarah Ponce and in our team internally. And then also get some of Valerie's initial thoughts as well. And then I can see if it would be appropriate for DHHS then to publish it on our website with the appropriate approvals with the DHHS logo on it. And then that would be the first deliverable. And the second one would be to work with the University of Utah on their own document that we would later, maybe that would replace our own potentially. So, okay, great. Thanks.
Yeah,
I just
yeah.
thought
And then
we could set that forward.
let's do it. I love it. And then that third thing, the updates, maybe we should do an annual update. Like these are all the conditions that were updated in 2023. The MS, the Crohn's disease, and I can't remember what else we did. I can't remember more than 6 months. But why don't we summarize the year, because it's only 4 or 5. And so let's summarize those so that Valerie can put it in her newsletter. We can post it somewhere, and then send that email to the executive email to QMPs, like, this is what we updated this year. Check it out.
Yeah. Yeah, I'll take a look at that as well with Sarah Ponce. That sounds good.
Rather than doing one at a time, we may as well summarize the entire year.
Right. And we do an annual report, but it's just for the legislative committee. And that is always done in November of each year. And so it's kind of an odd time to do it because it's November. But we can always do like by calendar year, completely separate as a way of summarizing the calendar year, right?
Yeah.
Yeah. I'll talk to Sarah about that. Sarah Dash, let's make sure we put that on a list of items to talk to her about.
You made me think of in family medicine, there's an annual national conference called the Family Medicine Experience Conference. And every year there's one guy that has a lecture called the top 10 things you need to know from this last year's research. And it's the most popular session in the entire conference because people just want to know, what are the top 10 things last year that were discovered that I need to know? And it's kind of that spirit of just get me the top 10 newest things that I need to be aware of because I may have missed it. So
yeah, I like that.
Okay, well, let's move on then. I think it's now, Misty, it's your turn. You want
Hi,
to talk
yes.
about the update for the advisory board?
Yeah, so I wanted to also thank everyone who contributed to the memo from our board that was presented at the Medical Cannabis Policy Advisory Board at last month's meeting. I think it really helped inform where we stood on one of the agenda items that were voted on in relationship to the list of qualifying medical conditions. So I thank everybody from the board who took time to review the letter that Matt drafted and we all edited, because it was very helpful for the purposes of our board in the Medical Cannabis Policy Advisory Board. I also want to thank Trevor, Rich, and Abigail and JD, who are all in the attendance list today. And if I'm remembering anything incorrectly, feel free to speak up and add to what I'm sharing with this committee. But the big thing is we are always looking for ways of building better communications. I'm looking at what's being presented right now, and it's okay. Is this what you're wanting me to speak on, Matt? Because I was actually speaking on what we talked about last month.
Well, no, you can just talk about what you want to talk about. It's your update.
Okay, I apologize because this was a different topic than what we had talked about. I was just what we were hoping to do is build better lines of communication between the different committees and boards in the medical cannabis program. I know each of our boards rely on what's known in the scientific literature, and we use the reviews that our board creates in order to inform our votes on the different committees. And unfortunately, when there is not a strong clinical trial history for some of the potential qualifying conditions, it leads us to somewhat dead ends where all we can say is not much is known about this topic. So if we want to truly support some of the other clinical facing committees, I think it's important that we build these lines of communication so that we can perhaps look at the list from the Compassionate Use Board and see what conditions are most being addressed. Trevor did a nice summary of those conditions and maybe focus our research efforts and reviews on some of those conditions to address some of those needs. And even consider when there is an absence of clinical trial literature to review and make recommendations on, at least acknowledge that there have been non-clinical studies conducted and that make a statement that there is a strong need for additional research in the clinical realm. If we can somehow better make aware the Medical Cannabis Policy Board and the Compassionate Use Board on the areas we're currently researching, and also have an up-to-date list of areas where they could use additional support, I think we can actually integrate some of the research activities of our board with the Medical Cannabis Policy Advisory Board, and even better support the Compassionate Use Board. So that was basically all I wanted to add at this point, was thanking everybody for their comments and suggestions on the memo the last time, but also to urge us to continue to try and build these communications and build the supportive relationship with the other boards.
Well said. Yeah, I agree, Misty, that we can benefit, because we're all trying to achieve some good things here. We have different backgrounds and experience. Our board is made up of a lot of research heavy clinicians, and then clinical experience heavy clinics, right? So we both have something to bring to the table, and then we can share that perspective with the advisory board. And so that policy that they were, the qualifying medical conditions, that was just a great example of how we can work together and provide input. Maybe Mike has more to say on the other topic, Misty, that was listed. So the advisory board was also trying to look in, the advisory board includes someone from law enforcement,
Yes.
you know, and their input on how this is impacting the public. And then Mike is involved with, well, Mike's really involved in, well, you say it, Mike. You provide a lot of information to our board, and we could be useful to the other board for what you deal with.
And
Yeah, I
before
think-
before Mike speaks, though, I want to also say that where we really added to the conversation was currently our Medical Cannabis Policy Advisory Board has some vacancies. So there was we don't currently have a qualifying medical provider, or our psychiatrist who was contributing originally to the committee. So when we shared the information we shared, I think it was very well received. We also had we had some clinicians in the audience who contributed to the discussion as well. So it was very timely and very appreciated. Go ahead, Mike. I'm sorry for interrupting you.
Oh, no. I was just gonna ask, what was the outcome, or where did that discussion end up with the Medical Cannabis Policy Board?
Yeah, we decided a majority of vote to keep the qualifying medical condition list as it was. And I think there was also some language there to work with the Cannabis Research Review Board for future discussions of the qualifying medical condition list. The minutes will be publicly available of the exact wording, but
Yep, this is Rich. That's correct, Misty. I know one of the things they recognized is that there's some great value in the Cannabis Research Review Board and expertise, and the great work that Sarah Ponce and Lauren Heath do to support this board. And they realize that it's good to benefit from the evaluation and vetting that the board does as they take a look at certain possibilities of future qualifying conditions. One of the realities is that it takes time. Good research takes time. And also the DHHS, we contract with Lauren to complete and do reviews, and she does a lot of work with the little time that we pay her to work, which is about a quarter of her time. And sometimes there's items that come up of high priority that take precedence. And so sometimes the timing of requests is a bit challenging, such that if a particular issue comes right before the legislative session, it's possible that we may not have time to dedicate Lauren and the CRRB to evaluate that issue within 1 or 2 weeks.
Yeah.
In fact, that's not likely to happen. And so the legislative session obviously starts next week and next Tuesday. And so it's just something to keep in mind is when we get these requests to review possible conditions to add, that good research does take time, and it does take prior planning to coordinate priorities. And so we do expect to be able to get to a place where we can dedicate some of Lauren's time to review some of these conditions that the industry, the Medical Cannabis Policy Advisory Board is wanting an update on. And we'll get there. But reality is that it does take planning and it takes time.
Okay, Mike, did you have any update with the public safety and or we can pass?
Nothing from public safety. I can mention that other, I know, or maybe if the appropriate Sarah is on to talk about it.
Go ahead.
That other one here was kind of around some information sharing. I think kind of two pieces of helping a medical examiner perhaps investigate cases where there's a death and there's medical cannabis involvement with that patient. A medical cannabis patient could exposures that get reported to us at the Poison Center as far as adverse effects, or someone accidentally getting into like a kid would we be able to tie that to any known, is this a medical cannabis or is this recreational cannabis coming from another state? Same as far as traffic records of we have this increase in fatal collisions, and we see that THC is commonly found. And are these patients involved in these collisions medical cannabis patients or not? So all of these different things and areas, and in this instance, centered around adverse effects, is there an easier or better way to help share between these different groups that are in different areas of the state and different agencies? Kind of part two of that was, well, what about adverse effect reporting, right? Are we tracking any of these as far as adverse effects, right? The analogy being something like FDA fairs or MedWatch, where you can say this thing happened to this patient. So someone can be aware to at least tabulate them or investigate things or make different recommendations about it, which would kind of be a separate piece of things, but would help all of us go together. And that was what this memo was about, was saying, hey, this would be nice, but it would take some work and perhaps funding to coordinate this and figure out the best way that all these different groups could communicate and have access to information to be able to kind of best inform decisions on all these different.
Thank you, Mike. I don't know if it was just me, but your microphone is kind of choppy, so I understood most of that, but
That's I heard that yesterday too, and I don't know what's going on my laptop. I'm gonna try one other thing.
Like it does better when you're leaning forward. When you're leaning back, we're getting kind of an echo.
Okay.
It's making it difficult to hear.
How about this? Is this any better?
That's much better. Yep.
Okay. I switched to a different microphone on these earphones, but the battery runs out in like 30 minutes. And so if I have it on for the whole meeting, then I run out of microphone. So I can repeat the short version of that would be sharing information about who medical cannabis patients are, whether it's related to just a fatality that occurs when the medical examiner is reviewing, a fatal auto collision where cannabis is detected in urine of people involved in that collision, or things that are reported to the poison center, and whether this involves medical cannabis, so we can be aware of the adverse things happening out there. And then part two would be establishing some sort of tool or system for QMPs or patients or otherwise to report adverse effects about cannabis, specifically medical cannabis. We, of course, take calls at the poison center about those sorts of things, but there's not a particular path that gets reported back to anybody. So that was the gist of this memo, saying, let's consider calling for this and asking for this and proposing this.
Great, thank you. And I think it's a good idea. Obviously, we're not going to be involved in policy, but data and information is already being gathered. This proposal would make that information useful if we can access it and then process it in a way to answer some questions. So that's what we're about. So I think it is a good idea. So we'll see where it goes.
Yeah, I think, if I'm not mistaken, the next step, if we approve of this memo, would be to bring it to MCPAB and see what their thoughts are on it.
That was my understanding as well.
Right. Yeah, and the MCPAB meets on Tuesday, January 16th. This is not on their agenda, but they could potentially include it in their February or March meeting. Yeah.
Hey, sounds good. Anything else that we need to do with this?
Is there an interest in voting on a recommendation that the MCPAB consider this potential amendment to the law to require that there be some data sharing?
I would make that motion. I would move that we would make I think there's still a few edits that need to be made to this document, but I think it should be considered as a recommendation from our committee to the MCPAB to make the data accessible for additional research.
Great. We have a motion to at least approve the idea of this recommendation with edits that could be done offline. Do we have a second?
Sure, I'll
since
second.
I've been involved. Third. Yeah.
We have second and third. Awesome. Russ and Mike. Excellent. Okay, before we vote, we have any further discussion on this motion?
I would just say this will require a lot of work, and just thinking of on my side of the poison center side, what it would take to integrate all these, and it's definitely money and time and personnel, and not like flip a switch and all this works tomorrow. It would be certainly an investment from lots of different people to integrate this, but I think is worthwhile. And of course, this is just making the recommendation to consider this, and there will be lots of other pieces to work out. And so I don't think this has to propose the full details of how this is going to say. It's not a budget. It's not anything else. It would be really great to share more data in multiple different directions.
That's right. Exactly.
It's even one step farther out, Mike, because it would be a recommendation in hopes of getting another recommendation.
Yeah.
Right.
But it's generally a good idea. Okay, any further discussion? All right, all in favor of recommending a recommendation? Say aye or raise your hand. Okay, good. Any opposed? Excellent. Okay.
I have a question. It's not an opposed. My question would just be from the patient realm. I know that concern when I talk with patients has always been from a HIPAA standpoint. And I know that research is good. We really want to make sure that transparency is good. Everybody's having the same conversation. But consistently what I hear from patients and sometimes providers is the concern is, you know, when we work with Suboxone patients, anybody can just access their records in the hospital. You have to have a separate step of security before someone can see it, because we don't want them to go in the ER and have there be some preconceived notion about the patient being on Suboxone for who might be there for pain. How would that kind of be addressed from the patient realm of just alleviating some concern that if they're pulled over, if there's a situation and they see that they have a card, there not being that preconceived notion? And I know that, you know, we have an amazing group of LEOs, but definitely I just think that conversation keeps coming up from both doctors and patients of our information is being put out there publicly, but it's still my private medical information. It's for my cancer, it's for my tumors. How is that conversation being had?
Well,
I know at least that law enforcement is already able to get that information. You know, someone's pulled over for suspected DUI, they're able to get that, the same as like make sure you don't have warrants out for your arrest, like on the spot. So that's already something that's capable. And I think whatever happens here has to be considered with, you know, what is public health, what is in the interest of public health in sharing. And I think that all fits within HIPAA, right, of the health department, and us with all that data has to be shared for the general public good versus what are you doing? No one's getting punished here, and this would be your medical cannabis card is going to be removed from you because one of these things happen. So I think all those things will definitely have to be in there of what does that mean and what level of data is shared about who the person is and who gets to see that information will definitely be important parts of this. I think when it's the state sharing data with itself and all these different aspects of data that already exists and the state knows about, and then how does that cross the lines when you're dealing with law enforcement and the medical examiner's office, then we're just dealing inside the same DHHS here, and just facilitating some of those things. I would say also there's no extra step that's required if a patient is on buprenorphine or Suboxone for reviewing that medical record. That's the same as any other treatment. It's not behind a second wall.
Okay, I work with a hospital and they have a separate set of security that you must access and you have to have permission to get into Suboxone patients. So maybe that
might be the case. I'm on our inpatient addiction service here at the hospital right now until there's no separate thing. Of course, no one should be accessing medical records if they shouldn't, but that's freely available, just like any other medication a patient is on. And that privacy is important, and other things of mental health can be kind of locked behind a separate thing if you can't access this unless you have a particular, you know, need to know about things. But just for clarity's sake, of buprenorphine doesn't live in any other particular world as far as a separate protection beyond the same protections that any patient record has.
In April, can you state your first and last name and your
Mhm.
affiliation for the record?
Yeah, my name is April Valle and I ran Terra Health, and we are now offering consulting services for primary care physicians wanting to offer medical cannabis services in the community.
Thank you. And just a reminder for public members, if you are not a part of the board, we're not supposed to make comments unless we're in the public comment period and the board chair calls on you. Just a reminder going forward.
I appreciate you guys.
Thank you, thank you. Okay, moving on to our agenda, let's turn it over to Sarah Ponce and Sarah Dash for research and education updates.
Yeah, so Sarah Ponce is actually out sick today, so I'll be doing the updates. I don't know if we have any research ones besides our partnership with the Center for Medical Cannabis Research. And then just some education updates. The first one I want to mention is that Dr. McKiff was featured in the Rural Health newsletter, talking about access to rural health. And you can see that in our upcoming CMC newsletter. It's a great article. It's really short, but has some good information as we're trying to improve health equity and access to our rural communities. And then some other education updates. We've been working with the Office of Substance Use and Mental Health to kind of do some more education, and they focus on like early psychosis, and we're just trying to have more conversations about that and making sure providers are aware of how medical cannabis could have an effect on that, and just making sure we're kind of covering all our bases. So we've been looking at more opportunities of places to educate the public with that group. And then I've been working with Linda Hansen at the Department of Public Safety. We're trying to create some more information and info sheets about medical cannabis and impaired driving. As you know, medical cannabis is becoming more popular and some people are new to the medication. We just want to make sure that they're aware of like the risks with driving and having all that information available. So once we have some education materials available, I'll share that with everyone. And then you guys may have seen an email from me about a QMP survey. And yeah, sorry, Misty, I saw your hand is raised.
Oh, no, I'm sorry. I
Oh.
didn't mean to. If I did, sorry.
Okay, no problem. So we've created a QMP survey, and we're just trying to gather some insight as to what kind of information QMPs are providing to their patients, if they're giving any documents out like brochures or one-pagers with information pertaining to medical cannabis. So if you haven't filled out that survey, we appreciate any feedback. Yeah, we're just trying to gather some input. And if you have any digital copies of things that you're providing to your patients, if you want to send those to me, that would be great. And I think we've gotten about 35 responses from QMPs so far, so we've been getting some good feedback there.
And Sarah, what's the deadline for that?
We haven't really set a deadline, but the end of the month would be great. I think I'm going to establish one in our newsletter because we're going to send that out and hopefully get some more responses. So we'll say the end of the month now.
Wonderful.
Yeah.
One other item, Sarah, that I was going to add is I know that Dr. McKiff, you're on schedule to present at the Utah Academy of Family Physicians, I think.
Yes.
A CME on February 5th and up in Park City, and on the topic of medical cannabis treatment basics, the endocannabinoid system and evidence-based guidance, correct?
Yep.
Yeah.
7 a.m.
Is there any way that could be videotaped and shared?
Let's find out, Matt. I don't know. They may protect it just because of it's CME that's paid for.
Yeah,
but we can just find out about that.
Yeah,
No
I know
harm in
there's a
asking.
virtual option available, so they might be able to record it.
Yeah. And also we'll be sharing information about that presentation coming up with medical providers throughout the state. And so if they're interested in going, even if they're not a member of that academy, they have to pay a higher fee to go, but they'd be able to go and listen to that either in person or virtually.
If I can also add, on Tuesday, January 30th, and I don't know if Valerie's still on, the Medical Cannabis Policy Advisory Board I'm sorry, the Center for Medical Cannabis at the University of Utah is sponsoring a symposium that will be focused on cannabis research. There's a registration involved with that, but it's really kicking off the center and highlighting some of the research that's ongoing with cannabis products. But also there's going to be breakout sessions available where we're basically going to try and build relationships between institutions within the state of Utah and anyone in attendance to maybe build research collaborations. So it would be a great opportunity if you have projects in mind of meeting current investigators in the field and maybe jump-starting some projects.
Yeah, thank you, Misty. Sarah Dash is awesome and has already reached out to include it in the newsletter. So we are lucky enough to have DHHS really supporting that. Sarah Ponce also reached out in order to get it out to all the boards. So thank you guys for all your support. Amazing. We hope to see you guys there.
Thank you, Valerie.
Sorry, I was on mute. Thank you, everyone. I put both of those conferences and symposiums in our newsletter too. So registration link and more information will also be in there for easy access.
Thanks,
And,
Sarah.
yeah, no problem. I think that's it for education updates, unless anyone has anything else they'd like to share.
If anyone, one other item I know we're going to put in the newsletter is if anyone has ideas about groups that we should present to as an office, talking about like a presentation on like the state's medical cannabis program in general, or if it's a clinical presentation, that would be something that we would coordinate with Dr. McKiff on to do. If you do have suggestions of groups, you're welcome to guide those groups to a form that we have them fill out. That'll be a link to that form will be shared in the update that Sarah's sending out within the next week. And when that goes out, people can fill that out if they're interested in having either DHHS or Dr. McKiff come and present on one of those. If it's clinical, it would be Dr. McKiff. If it's on the laws, it would be our office. We really want to do more and more outreach over time as the program grows and builds. So you're welcome to contact us directly also with an email if you have those ideas, but we'll be sending out a form as well.
We actually have the form already on our webpage. If you go to the medical cannabis website and go to contact us, we have a link where you can sign up for a request for a speaker. So
great.
It's already live if anyone has any suggestions.
Great. Yeah, I think that's it for research and education updates.
Awesome. And you made me think, Sarah, when I treat a new patient with cannabis, I always give them the paper for the Sublime study at the U. I know that that's been sent out before, but it might be worth trying again. I don't know how long they're going to keep enrolling patients, but the patient has to be a new medical card holder within 6 months to qualify for this study. And so a lot of my patients were well beyond that. So if I have a new one, I always give them a handout. It's like, join this study. So I want to keep promoting that.
Right.
Okay, so we're ahead of schedule, which is great. I don't ever complain about being ahead of schedule. So now we have 10 minutes to bring up anything the board wants to bring up before we do public comment. Is there anything else from board members that we missed, you want to talk about, we put on a future agenda? I don't know. Compliments to Michigan over Washington last night. I don't know what do you want to add?
Don't talk about the team up north, man.
Yeah, the team up north. Yeah,
That's how I refer to them.
You must be an Ohio State fan.
Yeah. Didn't watch the game. Just can't watch. I was just gonna ask Rich, do you have any insight of things that are known to be coming up in the legislative session for the board to be aware of. I know we've been asked about other things in past times, so I suppose whoever is planning whatever bills has already made their decisions. I don't know if you know about anything, just as a curiosity.
Yeah, that's a good, I can just take a brief moment on that. There are some items that the Medical Cannabis Policy Advisory Board has already recommended on, like on suppositories, for example, right? So we do expect that to be incorporated in legislation. Also, clarification regarding restrictions on advertising and targeted marketing. And the Medical Cannabis Policy Board approved a recommendation that lawmakers allow medical cannabis processors to do advertising and targeted marketing. If certain criteria are met under certain conditions, they would be allowed to do that directly to the public. And also, if it's targeted marketing about specific products, they could do it under certain conditions with individuals that meet those targeted classifications. We do expect lawmakers to move forward with that recommendation. Also, there was a recommendation that the law be amended to either create a tax credit or a tax decoupling for medical cannabis businesses that will make it so a business can write off some of their expenses under state tax laws. And that would help a business that's engaging in medical cannabis operations legally to be able to just enjoy some of the same tax write-offs that a regular business does with their business expenses. So the hope is that patients in the long run benefit from that, and that it can help even potentially reduce the price of products in the end, because a business will be able to write off more of their expenses and be more profitable. And we hope that translates into in a small way to a price decrease to patients. And there are a few other items related to also, I know related to, let's see, there's other items that potentially will find themselves into bills and that aren't public yet, and we'll see what those are as they come up. But that gives you, I know Utah Patients Coalition is got a list of proposals that they're trying to contact lawmakers about, and we'll see what happens with some of those as those become public as well. Yeah, I think that's some of the basics of what we do expect. The session begins next Tuesday and it lasts until, I think it's 45 days. So March 1st is the end, Friday, March 1st. So we'll know a lot more after Friday, March 1st. Oh, there's also, I think, a possibility that we'll see that psychedelic legislation could come up again in Utah. It came up last year. And there is some consideration of potentially that coming up again, and DHHS playing a role in a regulated psychedelics oversight program is something that is possible as well.
Okay, well, thanks, Rich. That's a big topic by itself, so we'll see what happens. All right, well, let's move to public comment. We'll take 10 or 20 minutes, whatever it takes for that. Again, some of the rules: take 2 minutes, state your name, affiliation, be respectful of time, all of that. So as usual, let's start with Dr. Mark Viner, who's got his hand up, and I always look forward to what he has to contribute. You're on mute. So
all right. Hi, can you hear me?
Yes.
Okay. Okay, my name's Mark Viner, MD. I don't have any formal affiliations. I'm just in private practice in Nevada. Okay, I got 3 quick comments from today. Number 1 is the Lauren's reports are really good and detailed, but I found that we should probably, if you could consider highlighting in a little box the type of cannabis used in the study that you're going to base approval or not. Because I think everybody here in the room knows if you smoke a few marijuana cigarettes, it's not going to cure your ulcerative colitis or Crohn's, but with a nanogram level in the blood. But if you're doing, and not high dose monodominant CBD capsules, but if you're doing microgram blood levels of whole plant extract, that might be a different, it's important to point out as a QMP trying to read the reports. There's too much variation in the products. Like just dronabinol has 3 different schedules. Which one, like for pain, obviously Marinol oral is not going to work. But so anyway, that's something to consider. Number 2, but I love those reports. So number 2 is the patient assessment form. I just noticed a couple quick things. You got to put in pre-pregnancy planning. It's otherwise under pregnancy and breastfeeding. You might want to include that. The direct acting oral anticoagulants are contraindicated at the Cleveland Clinic and Mayo Clinic. But you can read about why there. That's important. It's a contraindication. And the form is a little bit non-inclusive because what about non-competent patients like developmentally disabled or dementia patients? So they are not going to be able to calculate the dose. So you got to have something about that in there. And number 3, Dr. Moss, the poison control, I think it's a great idea because you know what frightened me the most? The differential diagnosis of cannabis intoxication includes anticholinergic poisoning, which ranges everything from tricyclic antidepressants to chemical war agents used by, terrorists. So it's in the differential if someone comes into the ER delirious. So it's very important. And I'd be happy to present on psychosis anytime. I'd send a memo to the, thank you very much.
Yep. Sorry. Thank you. 2 minutes are up.
Any other public comment before we respond? These are great topics. Well, I'd love to respond. Mark, thank you so much, Dr. Viner. I think those are great points. I mean, whenever I review Lauren's research and everything, that's the first thing I look at. Like, what did they use? Did this study account for different products? Did it account for different doses? And they're all over the map. A lot of the studies, it didn't really distinguish between it was edible or oral or inhaled cannabis products. So as research continues to evolve, hopefully we'll have some consistency in the products. Some of the research is better than others. So your comment is maybe as a board, when we do a review, maybe we should highlight a little bit clearer the variability or the degree of variability in the products used, because I agree with you wholeheartedly. It just makes a huge difference. And that's why I said in that patient assessment tool, this is complicated. When you're studying opiates, it's dose and frequency, and that's about it. But here you've got, the route makes a difference, the ratio of cannabinoids make a difference, all of this, and the strain of the plant, all of that makes a difference. And if we don't account for that, then how much do we, have confidence in the research? So I agree with you.
Yeah, I think that's a point well taken too. Being an educator, that's one of the problems with these research projects we look at, is that a lot of the studies are smoking, and we don't even allow smoking in Utah. And there's almost nothing on the variation of oral administration, and it varies so much. So I think he's right. Maybe we could be a little more clear, but we don't know because those studies don't often clarify it.
They don't. And it's a shame that they go to all that trouble to do a study and then they leave this glaring hole in the consistency of it. At least when we talked about suppositories, that was pretty consistent. You know, that's pretty straightforward on dose and administration. And so that's why that research wasn't half bad, right? Misty, we talked about that,
Yeah.
that actually showed great consistency and duration of half-life because it was really consistent. And that, to me, that was obvious. Now, we don't all like the idea of using suppositories, but the data demonstrated improvement because it corrected that error. So anyway.
And Rich, correct me if I'm wrong, but the board made a recommendation to approve rectal administration at the
Yes, to lawmakers. And so, yeah, that recommendation was sent to lawmakers immediately after the meeting that we had, and we would expect they'll take action on that.
That's
I
good
think
to
it
hear.
may also help address some of the needs if the Cannabis Research Review Board could also make a recommendation to the MCPAB, let me get all my acronyms out, that we need to make mechanisms available for researchers to have access to real life products, to be able to conduct the research that needs to be done. Right now, those mechanisms don't exist. Some of us are working actively in the background trying to create pathways for that, but maybe a recommendation from the Cannabis Research Review Board to the MCPAB, knowing that we are fully supportive of improving access to researchers through the Center for Medical Cannabis Research or even independent researchers, so that we can be working with real life products rather than things we order from Sigma, or if you can get a hold of them, the DEA.
Right.
I
I
second
know,
that. Yeah.
I know if the federal government ends up rescheduling cannabis, so it is truly a Schedule 3, then that'll open up some possibilities, moving it from a Schedule 1 to a Schedule 3.
Yes.
But we can't bank on that happening anytime soon, although it seems it'll be soon, because we know they're considering it. It's just a question of exactly when that would move forward. If that's the decision that they make, to indeed make it a Schedule 3, that seems like it's leaning that way.
But I'd be willing to make a motion that the Cannabis Research Review Board recommend to the Medical Cannabis Policy Advisory Board to recommend that a discussion of improving access to researchers to medical cannabis products in the state be researched and discussed.
And we would need that to be, if you'd like to, we could add that to the next agenda.
That's fine.
Yeah. And Sarah Dash can make a note of that, and yeah,
And
Dr.
maybe,
Rika.
yeah. I know we have some discussions coming up at the next MCPAB that may influence that.
Yes.
So it may just be in the form of an update.
Yeah, and we could do an informal sharing of information between CRB to MCPAB, and obviously you're also on MCPAB, Misty, so that's
Yep.
easily done. Yeah. Great.
Interesting. Cool. And thanks, Dr. Viner, also for that. I hope that's in the minutes, Sarah, that those recommendations for the patient assessment tool. I think those were exactly what I wanted, things that were missed. So those are very helpful recommendations. Okay. Any other public comment? This is great. Awesome. Dr. Viner, you could go twice if you wanted.
Dr. Viner, your comments are always very much appreciated.
Okay, thank you. I appreciate you letting me participate. I learn a lot as well.
Yeah, and on that last comment, Rich, I think the products, and I don't know much about that tax bill, but it seems like giving them a break was useful because these products have to be grown and cultivated, and that adds variability itself. And so anything that can promote consistency would improve our data and research.
Absolutely.
So if the growers in Utah can develop consistency in their products, I know my patients that they find something they like, and then if it's not available the next time, well, they drive to Cedar or Mesquite. They try to they want consistency because once you find something that works, you want to stick with it.
Yeah, that is one of the challenges that some patients encounter is the consistency, being able to find the exact same product each time they go. Some don't have a problem, but others report that that is a challenge. And I think as more and more our program matures, that consistency will improve. So that's one of the keys. Mm-hmm.
Yeah. And ironically, in my experience with patients, it's less about the dose than it is the ratio and the type of plant and the delivery.
Yeah.
It seems like the dose could vary more patient to patient, but the effect is more variable with Russ. I don't know what you think, Russ.
Well, I've had the same product used by multiple different patients, and one needed, 5 milligrams, and one couldn't take more than a quarter of a milligram.
Right.
So it varies a lot. The other thing that we haven't talked about, I don't know if it's even in our purview, we look at conditions, but have we looked at any data showing the actual absorption rate of certain cannabinoids in the body, depending upon the form of administration? We know there's different absorption rates for inhalation. There's different absorption rates for sublingual versus taking a pill and just swallowing the cannabis. And that, because those are recommendations I think we need to at least generally offer, so physicians know if you take it this way, you may only get 12% of the cannabinoid, but if you take it that way, you might get 25%. Do we have any plans to look at that?
I don't know, but that's a great comment because it seems like a lot of the research is out there. Everyone wants to jump to the end.
Right.
Everyone wants to publish something really fast, showing that it's great for this condition, and they're jumping to the end, and they don't do the basic research like you just suggested. That's foundational research that you would want before you even conduct a study to get to the golden goose at the end, right?
Yeah.
You need that stuff first so you can design a quality study. You need that data first. I think that's great. And I don't know.
I mean, I've seen some preliminary research on general absorption rates, but I don't know how standardized it was. And I have to look. I have some material I should look at, and I could maybe pass it on. But it matters. If you're going to the dispensary and you're getting a sublingual, but you don't take it as a sublingual, you just swallow it, it completely changes everything. So
yeah.
I think we need to at least offer providers some understanding about the form of administration, not just the product itself or the condition.
Right. And like you said, I think it matters more than the dose sometimes.
Yeah.
Well, and Russ, I agree with you wholeheartedly. And I think the most current data that's out there is with Epidiolex. Unfortunately, I think most of the cannabis information, pharmacokinetic and pharmacodynamic information that's available is quite old, like several decades old, and is in dire need of being updated via the different routes.
I think even what I have is a bit dated as well.
Yes.
Because no one's looking at absorption rates.
Correct. And the minor substrates, very, very little out there.
Yeah, most of it's CBD and THC and almost nothing on the other cannabinoids.
Exactly.
Yeah.
So,
and what you take it with matters too.
Absolutely.
Whether it's fat soluble or water soluble or, and we're not offering any guidance on any of this.
And
because I don't think we know.
yeah, and just a thought here is, Russ, I know that the suggested use guidelines do talk about dosage form,
Right.
that they don't go into detail, but the purview of the board is to evaluate the safety and efficacy of cannabis products.
Right.
And the dosage form and the absorption rate, I think, fits very tightly within that.
I would say so. Yes.
Yeah, we're talking about safety and efficacy, especially efficacy, right? If you want it to be efficacious in treating your condition,
Yeah.
you would need to attach that with a specific rate of absorption, right?
Right.
Sarah Dash, let's make sure we follow up with Sarah Ponce and Lauren later about potential analysis of absorption rate and gathering some research regarding those topics and potentially publishing some information, and maybe also sharing some thoughts with University of Utah Center for Medical Cannabis Research about some things they might be interested in publishing on that topic, Russ.
Yeah.
Yeah.
And it also matters as the patient's condition. I mean, we just covered colitis and Crohn's. A person with Crohn's is going to have a very different GI absorption rate than someone who has a functional GI tract, and a healthy one. So
I can share that one of the speakers at the upcoming center symposium that's being hosted on the 30th is Dr. Joseph Rauer from the Center of Human Toxicology, and he will be talking about some of this pharmacokinetic data that they've analyzed. So, and I imagine with the first round of seed grants that's coming out, I think analyzing for serum and brain levels is going to be a component in a lot of the, obviously, they're not in yet and no one's reviewed anything yet, but I think everybody agrees that that information is very important.
Yeah.
And just to add, Misty, we do have a neural behavioralist and a neurosurgery applicant. So I do think that that's becoming more prevalent within the scope of research for everyone. So, and Russ also is an external advisory board member with us. So Russ, please know that we'd love for you to be a part of any of those reviews as they seem relevant within your scope.
Sure.
Thanks, Val.
Okay, great meeting. Thank you, everyone. Anything else? Lauren, I saw that you're here. Do you have anything to say today? I'm going to put you on the spot.
Hi, Matt. No, I mean, I appreciate all the discussion today. I don't think I have much to add. I guess I will just respond to the comment about the pharmacokinetic data, to say, just because my I was on the board back in 2019 when they first started creating these documents, so my memory may be the longest. The board did review, some of that data that was available, probably the older data that was being discussed, and there is some basic guidance in the general document from the CRRB about different dosage forms. So we can definitely use that as a starting point to build off of. I think, especially now with some of the other dosage forms, it would be interesting to see if there's additional data that we could add to that. But I don't have anything else to add. I appreciate all the discussion today.
Great, thank you. Always, thank you, Lauren. Always appreciated. Okay, everyone. If there's nothing else, thank you all so much for your attendance today and your participation, your comments. Great meeting. I look forward to the next one. Is the next one going to be quarterly, Sarah? Is that the?
I think the next one is April 9th, if I have the date right.
Okay, April 9th, mark your calendars. It should be just as exciting.
And there's always, Matt, I'll add, there's always, if a lawmaker has an urgent issue that they need support on, where as board chair, you feel like the board should make a recommendation about something that doesn't require too much additional research, there's always the possibility that during the session, you could always convene and if it's an emergency or if it's urgent. But yeah, if nothing else comes up, then that is the next meeting.
Right, good reminder. We can meet if the legislature, if we need something like that, if the advisory board wants to address something and wants input, because again, especially since they have vacancies of clinicians on their board, we can respond with anything. So there's another thing. And then remember your homework. Let's finalize this patient assessment tool within the next 3 weeks so that we can get that. So that's your homework.
Yeah, and I can send out a Google Doc and an email with that so that we can all work in the document.
Yep. And then a summary for 2023, our updates. So that's our homework. And with that, do we have a motion to adjourn?
Move to adjourn.
Misty motion. We have a second.
I'll second.
Russ seconds. Excellent. All in favor of adjourning? Fantastic. I think that carries through our quorum. All right. Thank you, everyone. Have a wonderful day.
Thanks.
You too. See you later.
Thank you.